Welcome back. This is part 15 of step-by-step vitrectomy. Vitrectomy in ocular trauma. Trauma has many challenges. First of them is what is the proper time for intervention. Early intervention is beneficial in managing complications like retinal detachment and intraocular foreign bodies. But early surgery is often accompanied with high incidence of PVR. Visualization is somewhat difficult if the trauma is involving the cornea. Trying to handle the group to put the eye in a good visualization, or even if we are needing to put a temporary keratoprosthesis, we will put it until finalizing the vitrectomy surgery and then putting a graft. Dealing with lens and iris injuries. Sometimes the lens is injured with subluxation or even open capsule, and the iris also. As you see in this video, there is a corneal opacity at the site of injury, and this makes the visualization is difficult. The capsule is corrugated and somewhat fibrous because the injury was at an old time. After doing rexes, it's a hydrodelineation and hydrodissection, and then going for phaco. The lens is subluxated as we see, so putting a capsule tension ring to support the lens and then implanting the IOL. As you see, the iris is injured, so doing a papilloplasty to repair the iris and to regain the normal shape of the pupil. Doing a fourth row papilloplasty. Also in this case, as we see, there is a traumatic mydriasis, repairing the iris from down and repairing the iris from above. Doing a suture at the lower iris, doing a suture at the upper one, and regaining the shape of the pupil. Then, after dealing with the traumatized lens and repairing the iris injury, it is time to select the proper IOL according to the situation. In this case, after repairing the iris, then preparing to put a retropapillary iris screw lens, incurvating at one side, and then going for incurvation at the other side. Now, the IOL is properly centered, then finishing the operation. If the iris is severely traumatized, then scleral fixated IOL using a mani technique is the proper choice. Fixing the first haptic and then going for fixation of the second haptic. Going outside until centering of the IOL. In case of trauma, there is a high incidence of PVR. How to decrease it? At first, at site of trauma, we have to free the retina from any connections. Going for chororetinectomy with the help of diathermy. Doing an ILM peeling and extend the ILM to the site of injury if the injury is extending posteriorly. Then the most important topic is foreign body manipulation and removal. We will go on a journey for different ways in management and handling foreign body inside the eye. First case is a young child who was suffering from retinal detachment with past history of traumatic cataract surgery. As we see, there is an encapsulated foreign body. Removing the capsule, putting a viscoelastic, and then going with a basket forceps to remove the foreign body. As there is a rim between the IOL and the posterior capsule, so putting this foreign body in between and then opening the AC and removing the foreign body. The second case is a patient with signs of sclerotic changes, as we see, subbranchy spots, going for cataract surgery, implanting the IOL, and then going down. As you see, there is a vitreous haze, doing a core vitrectomy and searching for the foreign body. The foreign body is entangled below the retina at the periphery, fraying the retina, and then going for removal of the foreign body using a pars plana incision. The third case is a case just referred for retinal detachment surgery. As we see, there is something running below the macula, and there is a site of entry, so this is a foreign body. Making a temporary retinotomy, retrieving the foreign body from below the retina with the help of cutter, and then injection of viscoelastic, and then going for pars plana incision because the patient is phakic and no way to remove the foreign body except this way. Then going for a forceps, manipulating the foreign body in its small diameter and then removing the foreign body. Going for a laser on the retinotomy site. 3 months after silicone oil removal, as we see, there is no PVR, the retina is flat, and everything is good. So the tips and tricks. Always suspect intraocular foreign body in every case of trauma. B-scan may have fallacies, so CT scan is mandatory. Viscoelastics may help smooth extraction of foreign body. Choose the minimal foreign body diameter to grasp during extraction. Choroidectomy at site of foreign body impaction is valuable in prevention of BVR. Eyelid peeling protects against retinal membrane formation and macular buckling. And one of the important things is to be always minded with the possibility of endophthalmitis, especially fungal endophthalmitis post-traumatic. In this case was referred for just endophthalmitis. As we see, there is a hypopyon of a membrane on the lens capsule. Removing this membrane and removing the hypopyon and going down. The visualization is somewhat difficult. Going for a vitrectomy and then going for shaving, as we observe there are multiple colonies of fungal endophthalmitis. Going cautiously and going for shaving to remove as much as possible of vitreous, and this helps to clear endophthalmitis and to treat this type of disease. While going for shaving, I observed something lustering at the periphery. Going for a cutter and grasping it, it is a foreign body. Then opening a pars plana incision and removing this foreign body from outside. And finally, thank you.